Welcome to Healing Horizons. I'm Chris Daniels, and today we're exploring Ibogaine treatment in Mexico for veterans living with PTSD. This episode is about hope, realism, and making informed decisions. We'll unpack what Ibogaine is, why Mexico has become a hub, how it may impact trauma and addiction, and what safe, ethical care looks like. I'll share evidence we have, risks you must know, and practical steps for preparation and integration. Whether you're a veteran, spouse, or clinician, my goal is clarity without hype, so you can navigate options with courage, caution, and community. Let's begin. Thank you for listening today. First, the landscape. Post 9/11 veterans shoulder high PTSD rates, often alongside depression, chronic pain, traumatic brain injury, and substance use. Many cycle through insomnia, irritability, hypervigilance, and isolation that strain families and careers. Suicide risk remains unacceptably high. Each statistic represents a teammate, partner, or parent. Standard pathways help some, but far too many feel trapped between overactivation and numbness, haunted by moral injury and fragmented memories. Alcohol, opioids, and stimulants can become coping tools that worsen outcomes. This is the reality drawing veterans toward new approaches, seeking relief that addresses roots, not just symptoms, and honors their lived experience deeply. Conventional treatments remain essential. Trauma-focused psychotherapies like CPT, PE, and EMDR, antidepressants, sleep strategies, pain, and TBI rehabilitation. For many, these are life-saving. Yet a significant group experiences partial response, burdensome side effects, or difficulty engaging due to avoidance, stigma, or logistics. Some medications blunt emotions without touching nightmares, guilt, or cravings. Others conflict with co-occurring conditions. Long wait lists, fragmented care, and limited trauma-informed pain management compound the problem. When cumulative strain erodes hope, people understandably look beyond the usual toolbox. Exploring plant-based therapies like Ibogaine is often less about novelty and more about reclaiming momentum and healing for many. Ibogaine is a psychoactive alkaloid from Tabernanthe iboga, a shrub native to Central Africa and central to Bwiti spiritual practice. In modern clinics, purified ibogaine hydrochloride and total alkaloid extracts are most common, with different profiles and potencies. Unlike classic psychedelics such as psilocybin or LSD, Ibogaine is often less visual and more immersive, with an onirogenic dreamlike quality that invites deep autobiographical review. It also has unique pharmacology, metabolizing into norbogaine, which lingers and may support mood and craving reduction. This combination of acute insights and sustained neurochemical effects distinguishes Ibogaine within the broader psychedelic-assisted therapy landscape for some patients. Why Mexico? Ibogaine is not approved in the United States, but Mexico permits medical use in private clinics under oversight that varies by region. Over the past decade, experienced teams have developed veteran-focused programs emphasizing cardiac safety, stabilization, and integration. Clinics are accessible from major airports, with staff who coordinate transport and lodging. Costs vary widely by setting, length, and medical complexity, often comparable to intensive residential care. For veterans, Mexico offers lawful access, a maturing ecosystem of practitioners, and proximity to home. That said, quality is uneven, so careful vetting and medical consultation before travel remain essential for safety. How might Ibogaine help? First, many report rapid interruption of opioid withdrawal and reduced cravings across substances, likely mediated by norbogaine's modulation of serotonin, dopamine, and opioid systems. Second, people describe a structured autobiographical review that can recontextualize traumatic memories, lessen avoidance, and surface compassion. Preclinical and theoretical work suggests possible effects on fear memory reconsolidation and stress circuitry. Third, after the acute session, a neuroplastic window may open, weeks where sleep, learning, and habits can shift more readily. For veterans, this convergence creates momentum, alleviating withdrawal, reducing hyperarousal, and enabling deeper engagement with psychotherapy and meaningful routines back at home. The evidence base is growing but incomplete. Observational studies and case series show promising reductions in withdrawal, cravings, depression, and PTSD symptoms for many participants, including veterans. Some report sustained benefits at 3 to 12 months when paired with ongoing supports. However, there are no large randomized trials for PTSD, and the publication bias is possible. Outcomes vary, and relapse still occurs. Adverse events, particularly cardiac, are real. Ibogaine is not FDA approved, and it is not a cure-all. The responsible stance is cautious optimism, potential for profound change, anchored by rigorous screening, skilled teams, integration, and transparent assessment of results longitudinally. Safety must lead. Ibogaine can prolong the QT interval and trigger dangerous arrhythmias, especially in the presence of electrolyte disturbances, underlying heart disease, or interacting medications. Known interactions include many SSRIs and SNRIs, methadone and other opioids, bupropion, tramadol, certain antibiotics and antifungals, antipsychotics, and stimulants. Recent alcohol or benzodiazepine withdrawal can also complicate care. Blood pressure, spikes, ataxia, tremor, nausea, and insomnia may occur. Because risks can be serious, unsupervised or at-home use is unsafe. Medically supervised treatment with continuous monitoring, emergency readiness, and conservative dosing strategies is non-negotiable for ethical, evidence-informed Ibogaine care. Please prioritize medical oversight. Before treatment, a thorough screening is essential. This includes a detailed medical and psychiatric history, medication and substance review, physical exam, 12-lead EKG with QTC assessment, and laboratory tests evaluating electrolytes, liver and kidney function, blood counts, and infectious disease when indicated. During dosing, clinics should provide continuous cardiac and pulse oximetry monitoring, frequent blood pressure checks, IV access, and on-site emergency equipment with trained clinicians present throughout. Conservative protocols, clear informed consent, and documented emergency pathways to higher-level care are best practice. Quality programs also coordinate pre-stabilization, sleep support, and step-down planning rather than one-and-done encounters for sustained safety. Who may not be a candidate? Individuals with significant structural heart disease, prior serious arrhythmias, prolonged baseline QTC, or uncontrolled hypertension. Those with unstable electrolyte abnormalities, severe liver or kidney impairment, active seizure disorders, or pregnancy. People with a history of primary psychotic disorders, uncontrolled bipolar mania, or current intoxication or withdrawal. Anyone currently taking contraindicated medications that cannot be safely tapered and cleared under medical supervision. Also, patients without social support, a safe environment for recovery, or access to ongoing care may face unacceptable risks. Ethical programs decline or defer treatment until safety conditions are met for each individual. Preparation begins weeks in advance. Obtain medical clearance with your physician and the clinic, including a precise medication plan. Never stop or taper drugs without qualified oversight. Stabilize sleep and nutrition, hydrate, and reduce caffeine and nicotine if appropriate. Build coping skills through therapy, breathwork, grounding, and distress tolerance help during and after. Clarify intentions, specific, values-aligned goals for safety, relationships, and purpose. Arrange logistics, travel, communication, and post-treatment support. If substance use is active, coordinate a safe stabilization plan that may include detox in a monitored setting. Preparation turns a single intervention into a structured healing arc with accountable follow-through. What is the experience like? Dosing approaches vary. Some centers use a single flood within conservative limits, while others stage tailored doses with extended observation. Sessions can last 12-24 hours or longer, followed by days of recovery. Common effects include sensitivity to sound, ataxia, vivid inner imagery, and emotional processing. Many rest with eye shades while monitored. Providers track vitals, hydration, and comfort measures. Nausea or insomnia may occur. The acute narrative often feels structured, scenes, teachings, memories, yet interpretation unfolds over time. Expect ongoing fatigue and introspection for days, so plan light schedules and supportive check-ins before re-entering daily demands at home. Co-occurring challenges matter. Chronic pain can entangle with PTSD and addiction. Thoughtful, multimodal pain plans reduce relapse risk. Moral injury, violations of core values, requires compassionate processing, not just symptom reduction. Insomnia worsens mood, cognition, and impulse control. Simple sleep anchors and behavioral strategies help stabilize recovery. Traumatic brain injury can affect memory, balance, and overstimulation. Clinics should adapt environments and pacing accordingly. Coordination among medical, mental health, and rehabilitation providers ensures continuity. The aim is not merely fewer symptoms but restored functioning, relationships, and purpose. When programs integrate these dimensions, Ibogaine becomes a catalyst within a broader rehabilitation pathway for veterans. Integration starts immediately. Create a written plan for the first 6 weeks. Therapy appointments, peer support, movement, sleep, nutrition, and service-oriented activities that reinforce purpose. Pair insights with evidence-based therapies, EMDR, CPT, ACT, somatic work, to consolidate learning and address remaining triggers. Track outcomes weekly. PTSD symptoms, cravings, sleep quality, concentration, mood, relationships, and daily functioning. Use simple scales and share results with your therapist, primary care, and, when appropriate, VA providers, enabling collaborative adjustments. Expect variability. Progress is rarely linear. The goal is durable change measured in behavior, connection, and quality of life, not just a powerful experience but sustained practice. Families are allies. Educate loved ones, set realistic expectations, and agree on supportive communication and boundaries during adjustment. Ethically, we honor Iboga's cultural roots, support sustainable sourcing, and insist on informed consent without coercion or exaggerated claims. Vet clinics by verifying medical credentials, screening rigor, emergency protocols, dosing rationale, and integration follow-through. Seek transparent outcome data. Resources include reputable nonprofits, veteran peer networks, and crisis lines. In the U.S., dial 988 and press 1 for the Veterans Crisis Line. Consult qualified medical professionals before decisions. I'm Chris Daniels. Thanks for listening. Stay safe, stay connected, and take heart on your journey.